Audio recording for this meeting has begun.
Okay, Chris, I'm going to go ahead and turn things over to you if you want to go ahead and get things started.
Perfect. Well, I appreciate it. And good morning, everybody. And we'll go ahead and get this webinar started. We're going to talk today about the new CMS Emergency Preparedness Rule. It's not necessarily new, and we'll go over a lot of that information here shortly. But just to give you guys a little bit of a background about what the rule's about, essentially last year in November, CMS came out with a requirement that every healthcare provider comply with a new preparedness rule, and that's what this rule is. And it sounds very daunting and very overwhelming to comply with it. It does apply to everybody. But hopefully by the end of the webinar today, you guys will all feel a little bit more confident and comfortable in what it entails. We'll also give you guys through the Wyoming Primary Care Association, which again, I offer my thanks for allowing us to speak to you today. We'll give you guys some tools and templates completely free to you guys that will allow you guys to sort of become in compliance with the rule. And you do have to be compliant with the rule by November of this year. So our time frame is certainly coming down. As we go through the webinar, sort of a loose agenda. First thing we'll do is we'll go over a quick PowerPoint. The PowerPoint sort of talks about the rules and some things that you need to do to comply with it. Kathy, I think you wanted to take a break as well. Right after that PowerPoint would be a good time for us to take a short break if we still wanted to do that. Then we'll go over the tools, and then after that, we'll really be done. So throughout the webinar, throughout everything, please feel free to ask questions as much as you can via the chat feature. I'll try to keep an eye on that section of the screen and answer them as they come up, and then I'm sure we'll have a question and answer period at the end. So before we dive in, Kathy, do you still want to do that break after PowerPoint?
That sounds good. We can kind of take a poll of the crowd and see how everything's going. If everybody wants to take one, otherwise we can just keep going.
Perfect. Sounds great. So we'll go ahead and get started if there's no questions, and we'll dive right into the Emergency Preparedness Rule. Give you a little bit of background on where we're coming from in terms of our knowledge on this rule. We work in the preparedness space, particularly healthcare and public health preparedness space around the country, and we do a lot of work with CDC and ASPR. ASPR is the Assistant Secretary of Preparedness Response for the Department of Health and Human Services, and they're really sort of the creators and guiders of this rule. It's really rolled out through CMS, but it's designed to align with the preparedness work that public health departments and hospitals and Health and Human Services and FEMA do throughout the entire country. So it's all about alignment, and we already work with most of those groups anyway. So we sort of got brought into the CMS side work through our involvement with CDC and other groups. So we have a pretty good knowledge about what the rule is, not only from our experiences with folks throughout the country, but because of that work we do with those federal and state partners that really have a lot of compliance with the rule. That's not to say that everything I'm going to talk to you guys today is going to be all based in hospitals or based in public health or based at the big government level. I really want to make today's session be very applicable and very meaningful to you guys as primary care providers. That's another great mechanism for you to use that chat feature. If you feel like, well, hey, wait a minute, how does this apply specifically to me? Please use that chat feature and let us know. The rule is very all-encompassing, and we'll dive into that here in a little bit. It hits every single one of the provider types. So I will try to sort of narrow it down specifically to primary care folks, but please understand that it is a rule that is designed to work from everybody from major hospitals to organ procurement organizations. So it's very broad, which makes narrowing down its language and its requirements to a specific provider. I'm a provider and I have 1 MD and 3 mid-levels and 4 MAs, and it's sort of hard to narrow that down specifically on a webinar. So we're available to sort of answer questions specific to your provider after the webinar. So we'll dive right in. The first question that we always get is, why is this rule even out there? Why do we have this new preparedness rule that we have to comply with? And I can tell you there's two reasons that are best probably highlighted in real-world scenarios. The first one is sort of the national agenda scenario. If you look at the Hurricane Katrinas, you look at the Sandys, you look at the 9/11s, you have these situations where the entire healthcare network is impacted by significantly large events. It's not a matter of politics or opinions on global warming to say that there are more natural disasters, and those natural disasters have a higher impact because of the urbanization of the population. More and more people are living in cities. Those cities are usually around, they're either on the coast or they're near bodies of water or they're in ski towns, or in your guys' case up there, I'll use Casper as an example, or Gillette. There's a lot of industry near those cities. So events that happen near those population centers have much broader impacts than local government and the local hospital can handle. And because of those broader, more significant impacts, there's this national agenda to say the entire healthcare community, the entire healthcare network needs to be able to respond to emergencies. And I'll give an example of that from Sandy, from Hurricane Sandy. One of the significant challenges that they had in Hurricane Sandy, even though, we're in New York City, where you can throw a rock from one hospital to the next, the sheer amount of population was a challenge, but one of the other real big impacts was the out-of-hospital care all got shut down because of the hurricane. So home health organizations were no longer able to provide care. Physicians' practices, since a lot of physicians' practices aren't bound by EMTALA, we're shutting down our doors. What that did is that caused a massive influx of patients who were lower acuity patients. They all flooded the infrastructure that was still existing. And that infrastructure was predominantly hospitals and Red Cross shelters. Well, hospitals are dealing with higher acuity patients who are already impacted by the event, in addition to the fact that people don't stop having babies and crashing cars and shooting each other in disasters like that. So the hospitals simply were not able to handle the volume of people that resulted from the out-of-hospital healthcare network shutting down. The primary care providers, the home health agencies. So the hospitals couldn't take these patients because they were already at capacity, even though they're bound by EMTALA. There's no room, there's no room. The sort of safety net buffer organizations like primary care practices were no longer able to provide the care. So patients were self-transporting themselves to shelters, to Red Cross shelters. And one of the things that happened is, and we're all in healthcare, so we know that poor outcomes or negative outcomes is just a nice way to say that patients ultimately became fatalities from the event. There were patients who were on home oxygen and who were on routine maintenance care and routine maintenance medicine that had negative outcomes, both a severe exacerbation of their illness, and there were some fatalities because they had nowhere to go. And because of those situations, very quickly, the federal government said we need to make sure that we sort of ramp up our preparedness activities throughout the entire healthcare spectrum. So that's really the first reason, is everybody has to play. Last week we were, to give you sort of another example, last week we were in Arizona, in the Phoenix area, working with their healthcare coalitions to prepare for a massive surge event. There's 4.5 million people in that healthcare service area. There are about 1,000 hospital beds. Even 1% of the population being impacted by an event in the Phoenix area, there's 4 patients for every hospital bed. That doesn't work. So we have to make sure that we get the out-of-hospital network involved in preparedness. And that's really where this rule, the first reason this rule came about. The second one is that there were massive inconsistencies in not only in the broader network, but between hospitals. The assumption of what an emergency would look like for a long-term care facility or a physician's practice or a behavioral health institution was significantly different than what a hospital would think, or what a public health department would think, and what the government would think. So because of those two reasons, which are very sound reasons, they said, CMS and CDC and FEMA said, we need to sort of get everybody on the same page. And that page is, how can we create this consistent and comprehensive framework across the entire healthcare network? So that's where the rule came from. I'm not going to lie to you guys, and I'm certainly more than happy to say that I'm not biased towards this rule. It sounded like a sales pitch for the rule. I think we can all agree that the rule has a good purpose. The rollout of the rule was not necessarily done very well in the capacity that most people didn't even know it existed until it was already rolled out. And even at the CDC level, nobody's necessarily happy about the fact that the rule is sort of a rod rule. It's not a carrot rule. It's not if you comply, you will get a higher reimbursement rate. It's if you don't comply, you will not get reimbursed at all. So the rollout of it and sort of the implementation and the compliance of it, nobody's happy with, not even at the CDC and the ASPR level. But that's just unfortunately a matter of the money and where the money is. So it's sound and it makes sense. It could have been rolled out better. It could have been done financially a little bit better. But that is essentially why the rule exists. Move into who is affected. These are the official, formal 17 provider types that are affected. I can summarize all of this very easily for you guys and say that if you provide medical care to patients and ask for reimbursement from either Medicaid or Medicare, you are affected. That is the easiest way to summarize who is impacted by this rule. It is essentially everybody who provides medical care, with just a very, very, very few exceptions. One of them is public health departments, which I'm assuming nobody on the call is a part of. And the reason that the public health departments are not affected is because they're already, sorry, my dogs are hollering in the background. They already have preparedness plans. So it's sort of the implication that, well, since you're government and you already have a preparedness plan, you do not need to make another preparedness plan to comply with the rule. Your existing plan puts you in compliance. The next agency that is not affected is EMS, or ambulance services. Those ambulance services, I will tell you, will be affected within the next year. Again, that's probably nobody on the call, but just so you can understand, who's impacted and who's not impacted. And while it doesn't very clearly outline that physicians' practices and sort of private practices and primary care practices are, listed on this list, I can tell you from the chair of the committee that a physician's practice is expected to be in compliance with this rule. And while it may take time for them to get down to the point where they're evaluating and monitoring you guys and coming out and checking a physician's practice, I would tell you that they're going to do it. It may not be November 16th of 2017. The rule takes effect November 15th of 2017. You have to be compliant by then. I would be surprised if you've got a 3-year wait before you're going to be inspected in this, particularly in a state like Wyoming where there's less healthcare agencies and entities to inspect. The odds of you getting inspected sooner are, you're probably going to get inspected sooner because there's less folks to inspect compared to a New York or a California or a Texas. So really that's the easiest way to sort of summarize this is if you bill Medicaid or Medicare for healthcare services, you are impacted by this rule and you have to be compliant. And again, the rule takes effect November 15th of this year is when all the criteria we're about to go over has to be done. A little bit about the rule, sort of strategically. These are the three main points of the rule. I'm not a big buzzword guy. You probably will only hear me say synergy once, and I just said it. We're not that kind of consulting group. So the long and short of it is, if you really want to know the official formal of what it is and what CMS is looking for, they're really looking for us to do these three things. Protect physical resources, to maintain continuity, so we can safeguard human resources. It's truly all about keeping your practices open, keeping healthcare organizations open so they can continue to provide care, business continuity, so we can protect not only our patients and the community as a whole, but also our staff and other folks. So that's the official formal language from the rule. Again, I'm not a big fan of it, so I just put it there for your guys' sort of own purposes in case you guys do want to see that. The next slide here is really, there's two parts of it, but they're the same thing. And this is the requirements. This is what we have to do to comply with this rule. On the left side is CMS's sort of take on it. On the right side is a more logical breakdown that we've come up with for the rule. They're exactly the same thing. So it's not, you have, our 6-step process makes you non-compliant or more compliant. They're the same thing. It's just broken down a little bit more logically and sequentially on the right than it is on the left. So CMS per CMS, they want you to do this risk assessment and emergency planning. We're going to talk about those things. From there, you're going to create policies and procedures. You're going to have a communications plan, and you're going to have to train and test on all those things. If we look at it on the right-hand side, that 6-step process, that's really, it says the same thing, but it's more logical. And so I'm going to walk us through that real quick, and then we're going to dive into each one of these sections, and then that'll sort of close out the PowerPoint for us. So the first thing you have to do to be compliant with the CMS rule is you have to identify your risks. And an acronym, sort of a phrase you'll hear in the preparedness community around that is called an HVA, a hazards and vulnerability assessment. What are the hazards we'll face as an organization, and what are our vulnerabilities from those hazards? We've created a really simple tool that you're going to get, again, today for free to help you guys sort of do that process, and we'll walk through it here in the PowerPoint, and then we'll look at the tool as well. But you really have to say, what can go wrong? And what are the impacts of what can go wrong to me? And that's sort of the first step. After you say, hey, what can go wrong, the next step is to say, well, how are we going to respond to those events? What is our plan for how we're going to respond? And there's 3 specific components of those plans that CMS is looking for. Now, CMS has said, we want you to have 3 plans. We've combined those into one document. It's one tool. It covers all the stuff. It's all there, but it actually makes your job of writing these plans much, much, much simpler, and it still gets you 100% compliant. So you have to create plans, but we've got it to where you're going to sort of create one document that is all 3 plans. The next thing you have to do is training. We'll talk about that a little bit. One of the things I will tell you on this training aspect, if you think about it, we've identified what can go wrong. We've created our plans. Now we need to train our staff on what those plans are. One of the things I'm gonna sort of highly encourage you guys to remember is that training is the easiest thing to do, and it's the easiest thing to fail. CMS wants to see a well-organized and formalized training program. Giving your staff a flyer or sending out an email is not going to make you in compliance, and you will not be in compliance with the rule. And what a simple reason to get a statement of deficiency for. To say, man, we could have done a better training, but we sort of just checked the block on it, and now we're not in compliance. We've done all this work, but because we didn't do good training, we're not compliant. So we're going to give you guys some tips on that as we move into the PowerPoint here. But I really encourage you guys, when you think about the training, is don't look at that as a check the block thing. It's so easy to do, but it's also so easy to sort of halfway do and fail. And that's really a bad reason to be non-compliant. The next one is, after, again, if you think about it, what can go wrong? And number one, what are our plans? And number two, train the staff on those plans. And number three, now we have to exercise. We have to practice. And we're going to go into those requirements a lot when we get to that part of the slide, because these, the exercise requirements are intense. It is not, and I say this anecdotally, we were working with a group in Colorado on this, and the whole time I was going over the presentation and talking about the rule and what they had to do to be compliant, the physicians and the office manager, the practice manager, were like, "Oh, we're good. We don't need to worry about it. We're good." And finally, I had to ask them. I said, "God, you guys must have really, really, really strong preparedness activities. Do you mind sharing some of them?" They said, "Well, we do quarterly fire drills, so we're good." The exercise requirement that CMS is looking for is far beyond quarterly fire drills. And we're going to talk about groups that you can participate with already within your sort of healthcare network that is going to make complying with these exercise requirements very simple. It's free. All you have to do is participate. It can make complying with this entire rule free if you participate. So when we get to that portion of we dive into it more deeply here in a few minutes, I'm going to heavily advocate for you guys to be members of your healthcare coalitions. Again, it's not a sort of shameless advertising for the coalitions. They're not paying me to say that. It's actually to help you guys out. There are already groups that have to do this. They're required to do this. Why not piggyback on what they're doing and get it done for free? The exercise requirement is very intense. It is above doing fire drills. So why not get on with groups that are already doing it for free? The last two steps are pretty simple. Excuse me. If you think about it, we've identified what can go wrong in 1. We've come up with plans. 2, trained. 3, we've practiced them. Now we need to evaluate in step 5, how did we do? If one of the challenges is we could never get a hold of staff, then when we do the evaluation, we need to say we could never get a hold of our staff. Or we ran out of supplies immediately, or the phone systems didn't work. In this evaluation process, you're saying, hey, based upon those exercises, this is what went wrong, this is what went well. And then from that, you move into step 6 where you say, okay, based upon what went wrong, what can we improve on? And one of the things an evaluator will look at over a long time, 3 years down the road, if you've consistently had the same opportunities for improvement and you've never addressed them, then that tells me as an evaluator, you're not evaluating and you're not doing an improvement plan, and you're not adjusting your plan to address it, so you don't have a comprehensive preparedness program, because you're basically saying, we could never get a hold of Dr. McDreamy. We still can't get a hold of Dr. McDreamy. It's been 5 years since we've been able to get a hold of Dr. McDreamy in an emergency. So what have you done about that? And again, it's a simple thing to mess up, because it's almost like, well, that's not hard to fix, but because it's so simple, we don't do it. And when we don't do it, we're not in compliance. So that's really the 6 components of what you got to do in the rule to be compliant. The tools we're going to give you sort of solve all those problems for you. This is just a little bit more blown up version. Pretty sure you guys are going to get copies of this PowerPoint. Plus we explain it all in the tools that you'll be provided. But this is just a blown up thing. Again, do your risk identification, step 1. Create plans, step 2. Train your staff, step 3. Do exercises down there at the bottom. We'll talk about those. Evaluate, improve, and you have to do this every year in perpetuity. There's no end date for this rule. Obviously, as you go, the first year is very labor intensive because you're starting from scratch. And the next year, you're not creating an HVA. You're not doing that risk identification process from scratch. You're just saying, hey, has it changed any? Have we increased our service area? You know, have they just built a huge refinery next door to us, which is going to obviously increase our risks? What does that do to our plan? So you're not having to reinvent the wheel every year, but you need to do these 6 steps every year. So with that, I think we're about to dive into the specifics. The specific parts, we'll go into a little bit more detail on these, and then we will be done with the PowerPoint. So the first step is that risk assessment. The biggest thing I'd ask, or there's 2 big tips I'd give you guys on this to be in compliance. The first one is actually at the bottom of the slide. Don't try to invent the wheel all by yourself. Your local Office of Emergency Management in your county, your local public health department, your local healthcare coalition, and what a healthcare coalition is there's multi-county sort of areas. You guys have 5 healthcare coalitions in Wyoming. And on the questions and answer, I'm more than happy to sort of go over the service area of those coalitions, but essentially the 4 corners of the state are coalitions, and then right in the middle is another coalition. Is a real layman's way to sort of break it out. They already have to do your local Office of Emergency Management, fire departments, police departments, hospitals, and those healthcare coalitions already have to do HVAs. They're required to do them, so they already have them. So I can tell you, if you guys are around Casper, one of the primary things that are in the primary risks that are based on your local government's HVA is an industrial accident. In Cheyenne, I can tell you that CRMCs, one of their Cheyenne Regional Medical Centers, one of their primary risks from their HVA is a train derailment or an industrial accident at the rail yards there. Thermop, Poison State Reservoir. As you go through, the point I'm driving at is local entities around you have already done these HVAs. So ask them first. Say, hey, can I get a copy? A lot of times for government, you can actually look at the County Office of Emergency Management. They post it online and say, what are my risks? What do we feel risks in our area? So you're not starting from scratch. The next tip I would give you is you have to consider sort of 4 different avenues of risks or vulnerabilities for your organization. And this is sort of where it sounds like I'm contradicting myself, but really what I'm telling you to do is do this risk assessment in a logical sort of process. Talk to your local partners first, get their risk assessments, but you can't adopt that risk assessment blindly as yours. What a risk for the entire county is not the same as a risk for a physician's practice that's in downtown Lander or in the middle of Riverton. Look at that risk assessment and say, yes, a blizzard, a flood, wildfire, those are big risks for me as well. Those meet our natural disaster risks, those 4 categories. But what about man-made disasters? Is there a concern because of my provider type that I'm at risk for an active shooter event? Because of the patients I deal with, do I have a risk for something else going on? If I am right across the street from a refinery or a rail yard, what are the risks to me that are more specific? If you're directly across the street from a refinery, that refinery may not be a risk that is significant enough for your county to identify, but it is obviously a significant risk for you. So that county HVA is just your starting point. Then you say from that, okay, let me look at these 4 categories. Natural disasters are pretty much universal across the county. But man-made, let me think about the specific things that could pose a threat to me in my practice where I am at. Disruption of service it begins to drift even further away. What if I can't get my labs picked up? What if I do all of my imaging remotely and we lose internet service? What if we don't have pharmacy? What if we can't get our supplies? What if we can't get trash? What are the impacts specific to your organization? And as you get more specific into healthcare and what's specific to your practice, you're going to see that the county HVA, it really only becomes a starting point. You're going to have to do a lot more work as you go down this list to get into the specific impacts for your organization, because your county office of emergency management doesn't know anything about labs and farm, and they don't know any of that stuff. They know fire, flood, terror. They don't know the impacts of not getting red bag picked up from your, or not getting suture from your practice or to your practice. And then finally, technology. Technology is one, it's a big risk to healthcare because so much of what we do is now based in technology. We have the requirement now to do electronic charting and have electronic medical health records or medical records. What happens if we lose that system? What happens if we lose all internet? What are our plans to manage these sort of things? So the tool that we have sort of walks you through these steps, and we'll look at it here right after the PowerPoint, but we've got some sort of screenshots from it here and sort of things drawn out on how you'll do it. The first thing is you got to identify your hazards. Again, talking about those 4 categories: natural disasters, man-made, interruptions, technological kind of issues. After that, we're going to identify a probability and an impact. How likely is the event to happen, and how bad is it if it will happen? So, a 1 on probability means it absolutely positively will not happen. A 1 on impact is this is not even going to be a hiccup for our practice. Whereas a 5 is this event absolutely will happen in probability. And in terms of impact, a 5 is this is catastrophic. This will shut down our practice. So you're sort of, what are our risks? What are their probability impacts? And you're going to rank them. And the tool we're going to give you to do that is right here. And I have some joking ones in here to sort of, to help sort of go through the process a little bit. So I'm a little bit of a nerd. We'll use alien invasions first. What is the probability of an alien invasion? Well, there's more stars in the galaxy than there are grains of sand on the Earth. So in this first column here, you can see we've got alien invasion across and then probability. Remember, a 1 means it absolutely positively will not happen. A 5 means that it is going to happen. It will absolutely happen sometime in the future. So let's just say with all the stars and all the solar systems and all the planets, we can't necessarily rule it out. We can't, so it's not a 1, and we can't necessarily say it's going to happen. So it's not a 5. So let's give it a 2. So in terms of probability, we know that the probability, the likelihood of an alien invasion is a 2. As we move over in the next column, we can do some mitigation for that. We can reduce the likelihood of that alien invasion happening. Since 1939, we've been blasting our culture out into the heavens. And if anybody's watched any election or reality television, they probably don't want to come to our planet. So we've done a little bit of mitigation. So while our probability is a 2, maybe we can subtract a 1, because who wants to come to this planet after seeing everything that we put on the airways? So our overall probability score, that first gray column, takes us down to a 1. We're not worried about it happening. You're going to do the same thing for that impact column as you continue to move over on that alien invasion row. Let me see, I could probably draw here. Possibly. No, I can't. Here we go. So remember, let's make this a 3. We've said, all right, alien invasion, we can't say it's a 1 because people are going to, there's a chance it can happen. We also can't say it's a 5. We've done that horrible broadcasting for all that time. So we know that we can subtract 1. So in the end, our probability score is a 2. Impact. If the aliens come, odds are they're going to be the top carnivores on their planet. They're going to rock our world. It's not going to be as bad as Independence Day. The movie itself is horrible, particularly the sequel, but it's not going to be that bad. But it's going to be bad enough. So let's say the aliens come, they're going to absolutely rock our worlds. It's a 5, and you can see how that impact now is a 5. It's significant. It's catastrophic. It's end of the world kind of stuff. Preparedness, we're all a little bit of preppers at heart, so we'll give ourselves a -1. So in the end, we come up with an impact score of 5. So in the end, our probability of an alien invasion is a 2. Our impact is a 4. And you just go through, you guys can do this after we're done talking and say, God, the probability of a bad speaker, Chris could have really stunk. In reality, he absolutely did stink. So in the end, he's a 3. The impact of a bad speaker is over lunch on a Wednesday. I would say that's a 4. So we can't really do anything for that other than we've got snacks while we're sitting on the webinar. So you can sort of see the same process. You just go down this column here, list out everything, talk about your probability, then talk about how you've given yourself some credit for mitigating it, talk about your impact, give yourself some credit for some prep, and in the end, your goal is to have this final probability score and this final impact score for the first half of this exercise. Then what you will do, let's remember alien invasion is a 2 and a 4. You come over to this, which again is on the tool, and you say, all right, an alien invasion probability was a 2. There's our 2. But the impact of it was a 4. So right here, we would say, I'm not going to write that all out because we'll be here all day, but in the end, our alien invasion is a yellow. The risk and likelihood of an alien invasion is a yellow. There's some trickery in this tool. There's a natural human disposition to focus on what happens the most often or what will be the most catastrophic. So to focus on this end of the spectrum and this end of the spectrum. Or what we see all the time that's just annoying. Well, these are not the areas when you want to make your preparedness plans because you either A, manage them every day, B, while they're very likely, they have no significant risk to your organization, or C, yeah, they're catastrophic, but the likelihood of them occurring is so small that it doesn't matter. The trickery in this tool is that by getting you to do this first, then laying it out on this, we get you to focus your preparedness plans only on the orange and the red. And these are the areas that you really need to plan for as an organization for your preparedness. You can certainly drift over here some and get into this column, but don't write your preparedness plans around these 1-1s or these 2-2s or even these 3-3s because they're not going to be significant enough to where you're even going to use your plan. What you're focusing on is you're focusing on this orange and red instead. So really what you can see in this first step, and that's it for the first step, is list out your risks, list out their probability, list out their impacts. Once you get those numbers, come over here, graph it out on this chart, and you'll end up with this sort of triangle of doom, and that's where you want to work on. That's what you want your preparedness plans to focus on. So that's really it. If you can fill out that tool, you are already 1/6 compliant. And honestly, you can do it in probably a day. The only other tip I'll give you on filling out that tool is you do not want to give it to the person in your organization that is like the most absolute paranoid person on the face of the earth, and everything's going to go wrong because you're ultimately going to end up with nothing but 5s and 5s. The flip side is you also don't want to give it to the person that is the most laissez-faire. That's like, nothing's ever going to happen, and you end up with nothing but 1s and 1s. As a, maybe you get, and I'm always a proponent for doing it as a team. Maybe you get QMAs, a mid-level, the business manager, the practice manager, whoever. Maybe you involve somebody from the hospital. You say, hey, come on over to our practice. Honestly, the Healthcare Coalition people would love to help you guys with this. And as a group, you just sort of say, hey, let's take 30 minutes and come up with this first sheet, that tabled sheet, and say, okay, what is this going to look like? In the end, once you get that triangle of doom, the next thing you do is you start writing your plans. Remember, that was step 2. We'll go through this in the tool. It's almost easier to show you in the tool than to walk through it. What I will tell you is the sort of overriding suggestion I have for you guys is do not make these plans ridiculously large or ridiculously detailed and complex. The biggest thing that we always encourage folks to do when they write preparedness plans is focus more on command and control and coordination. How are we going to communicate, respond, and work together regardless of the event? In preparedness, it's called an all hazards approach. Not we have a plan in the event of a fire, we have a plan in the event of a flood, we have a plan in the event of an active shooter. There are specific components that we'll talk about in policies and procedures for that. Your plan is, regardless of the emergency, how will we activate our plan? How will we notify folks what's going on? Where will we set up sort of our command and control mechanisms? How are we going to communicate with each other? Regardless of the event, how are we going to do that? Those are the big things that you want in this plan. So it's more of it's almost like a business plan, I guess you could say. And how are we going to operate our organization responding to whatever the emergency is, as opposed to an incredibly detailed plan that's 450 pages long that nobody will nobody will manage. To give you some sort of a litmus test or a measuring stick, the entire plan for every entity in the Phoenix area, the 3 counties in the Phoenix area, response, tools, trainings, everything under the sun was 45 pages long. And that is, bear in mind guys, that's government, emergency management, federal, state, local, EMS, fire, long-term cares, public information, social media. Your plan shouldn't, I mean, you can certainly have them that long, but do not feel like you need to make a plan that's 400 pages long. If you do, you're just doing yourself a disservice. Focus on a very intuitive and understandable plan that's sort of like, and I say this jokingly, the complete idiot's guide to how we're going to respond to an emergency. That's what your plan should really be. And when we go through the tool, it'll make a little bit more sense. These are the 3 plans. Again, we've consolidated all into one tool, which we'll look at after the PowerPoint. The emergency plan, again, we'll talk about that at the PowerPoint. There's really 2 parts of all plans, which is one of the reasons we've consolidated them. There's that administrative stuff, which we'll sort of talk through in the tool, and there's the operational stuff, which again, when we look through it at the tool, it will make much more sense. The comms plan is really just, the communications plan is, how are we going to talk internally between staff? And honestly, that's really just a matter of how are we going to talk? Phone, email, but we're a single facility physician's practice. We don't need to talk, you know, we can talk to each other. Voice. We have, 7 facilities throughout the Casper, Lander, Riverton area. Well, how are you going to communicate as an organization in your facilities throughout there? So that's really the comms plan, and again, the tool makes it much more easy to understand. Policies and procedures, we'll talk about these again a lot more when we get to the tool here in a second. Just to understand that the emergency plan, remember I said, is very broad, it's very strategic, it's very 1/30,000 high level. The policies and procedures is where you would get into your more specific and detailed stuff. And we'll, again, when we look at the tool here in a few minutes or after break, if you guys choose to take a break, it really does make it much more simple to understand. So I don't want to go too much into it here just because the tool is so much easier to understand than me trying to describe it on a PowerPoint. We've already sort of gone over most of these. We've already combined them into one document for you guys. The fact that we're doing policies and procedures as annexes, and when you see the tool, you'll see that it's much easier to change a 2-page policy and procedure than it is to change a 40-page plan. So that's why we always encourage you guys to put the detailed stuff in an annex. We have a joke, we call it the good idea fairy. I'll give you an example of a good idea fairy. We worked with a major healthcare system on the East Coast, and they have multiple facilities, and they were like, you know, in the event of an emergency, we really need to be able to get a hold of anybody at any time in the entire organization. So they went out and spent well over 6 figures on buying SpectraLink phones, voice over IP phones, that every single nurse, mid-level physician, pharmacist, everybody could carry in the event of an emergency. It was a phenomenal idea until you consider the fact that in any major emergency, the first thing to go is probably going to be your tech and your internet. So people are now carrying these gigantic bricks, and then that can't be used. And then the other thing is nurses and physicians and everybody else are under the sun already have 3,000 things hanging off their scrubs every day. Giving them a 5-pound phone to hang off their scrubs as well is nobody's going to use it, and no nurse did. And it took, at best guess, it would take them over 2 hours to hand out all the phones to all the staff. So it was a good idea ferry. It was a 6-figure plus good idea ferry that it seems like a good idea, but you got to sort of say, well, is this logical? So when you write your plans, just try to do that litmus test of the good idea ferry. The comms plan already handles these contact information. You have to be in compliance with all federal, state, and local laws. I certainly am not going to go into great detail on Wyoming's crisis standards of care and those things. It gets very legally ambiguous there. It's based upon a whole number of things, which again is a great reason for you to be a member of the Healthcare Coalition, because if a disaster is declared, then the governor can waive a great number of rules. People can practice way above their everyday scopes. You can go into crisis standards of care, you do triage. There's all sorts of things that come up in an emergency in terms of healthcare. Your plans need to be written so they will be in compliance with state, federal, and local laws. But in this webinar, we're not going to go into great detail on what those laws are, because they're unique to every state, and B, because really I would encourage you to partner with your healthcare coalition, because it's not as simple as non-emergency do this, emergency do that. There are a plethora of different sort of yes-no decision tree diagrams when it comes to this. And then your end result, again, we're giving you this one tool. So you don't need to worry about it. It has everything in it. So now if you think about it, we've done the HVA. That was the alien invasion thing. That was step 1. We've now created this plan, step 2. And we've combined those 3 plans into one document. The tool I'm going to show you walks you through it very simply. Now you need to train. The biggest thing I'm going to tell you on the training is that CMS is absolutely 100% going to be looking for this well-organized training program. So here's my suggestion to you guys, and one of the tools we'll provide you today will sort of encapsulates a lot of this as well. As you come up with your plan, and it's all done, do a little come up with 25 questions from that plan. Question 1, when we activate the plan, how are we going to notify all the staff? A, carrier pigeon. B, our call down tree from our staff roster. C, email, whatever. And just create sort of that 25, 30 sort of cache of questions, and then train staff on the plan. Do an in-service. I wouldn't necessarily give them the plan and ask them to read it. That's the worst way to get anybody to learn a preparedness plan. If they want to, cool, but people don't usually learn that way. It usually needs to be interactive. But then when they're done, give them sort of 10 random questions on a piece of paper, have them fill it out. If they get above the 70%, they pass. And then what I would do, if you have an electronic training system, like a computer-based training system that you keep all their BLS and ACLS and PALS and everything else in, awesome. If you don't, just make a 3-ring binder that says Emergency Preparedness Plan Training. Take that passing test, put it in there, so when the evaluator comes and the evaluator says, Can you show me that you have a well-documented training program? Yes. Here's the training I provide them, and here's how I test all of my staff. Here's my 3-ring binder with all of my staff's tests from the last year that shows that they are aware of and can apply the things that are covered in that training program. The evaluator will be so taken aback and impressed by the fact that you are even testing them, that you have now completely met this requirement. They're not going to dive in any further. I would encourage you not to keep that in like their employee file. I've always been a proponent of don't show the inspector more than they need to see, so giving them a whole employee file when you could just give them a 3-ring binder that has everybody's test in it is, you certainly do that, but I think you push yourself at more risk giving an inspector or an evaluator your employee's file. But if you just say, here's my 3-ring binder for all my training, here you go. It shows that everybody's not only been trained, but that I've checked their proficiency in it by giving them this test, and here's all their tests. You've met this block. The times that staff need to receive training is 1, anytime a new employee comes into the organization, which again, you're already doing onboarding anyway, so just shove in that quick emergency preparedness plan training in the little quiz. And then annually, you'd probably check in BLS annually anyway, so just tack this onto that sort of annual review process. But train, do the quiz, put it in a binder or put it in your computer system if you have that. You will meet this very easy requirement. If you just send out an email to everybody and you can't demonstrate that they have been trained and they can't demonstrate their proficiency, that demonstrate their knowledge, you sort of run into, at best, the inspector will say, well, let me go ask your staff about the plan, in which case your staff are going to have to be coming up with stuff, which is never good. Or at worst, they just automatically fail you and mark you non-compliant for a very easy component of the plan to meet. After that training, we're going to get into the exercise component. And this is where, remember I said in the beginning, this is sort of the fart in church portion of this plan or this requirement. But you can make this much easier by being a member of your healthcare coalition. For everybody on the phone right now, assuming we're all primary care practices, and by and large, all 17 providers have the same requirement. There's only a few that don't. You're required to participate in 2 emergency preparedness exercises every year. Those exercises, again, are not fire drills. They are actual big emergency preparedness exercises where we are saying, and again, I'll use Arizona as an example, or better yet, we'll use Thermop as an example. We are saying the Boise State Reservoir Dam has broken. We have 90 minutes to evacuate Thermop before we're under 11 feet of water. What are we going to do? How are we going to manage the evacuation of the hospital there? How are we going to manage these other things? Now, you guys as healthcare providers aren't doing that. You have to be involved in how they're going to do that, though. And that's really where this first exercise requirement has scared a lot of people. Because the requirement is that you have to participate. Of those 2 exercises that you have to do, one of them has to be a community-based, full-scale exercise. And what that community-based, full-scale exercise means is the dam breaking at Thermop, a novel influenza, an industrial accident. We just did one in Alpine and Afton for the Region 4, the healthcare coalition there, where it was a mass casualty exercise with a 30-pack bus, hit a 6-pack family van with, there's got 36 injuries, including 6 fatalities and 4 PDs. That is a community-based exercise. It's big scale. It's not just within your organization. It's not just within a hospital. It's EMS, emergency management, law enforcement, hospitals, long-term care facilities. All these folks would respond to that type of event. Remember, the premise of this plan was, how can the whole healthcare network respond better to a Hurricane Sandy. So they're going to want to see that your plans in this exercise component demonstrate that you can respond as a whole healthcare network to the Hurricane Sandy. The other one, and I'll get into more details about how the Healthcare Coalition can help you that in a second. The other one is that additional facility-based full-scale or tabletop. That's just within your individual organization. Honestly, what I always encourage folks to do is we've lost IT, or we've lost EHR, or we've had an active shooter, or we've had a massive weather event. It's something that's, it's not impacting the entire healthcare network and emergency management, law enforcement, everybody under the sun. It's specific to your facility, and it could just be as simple as getting the practice manager, maybe if you have a lead MA, and one of the providers to sit around and say, okay, boom, this has happened. Let's talk and walk through it. A lot of times people ask those to be externally facilitated. We externally facilitate, we plan and facilitate and do those things because it's sort of hard to practice it if you know what it is. It doesn't have to be externally facilitated, but it's again just something to say, how would we respond to an event that's more specific to us? So I'm going to take about another 2 minutes into this because the rest of them are done, and then we'll be right at the break. Remember I mentioned healthcare coalitions, and let's think about what probably has all your jaws dropping on the phone, which is that big community-based full-scale exercise. That's a lot for a physician's practice or long-term care, even a hospital, to take on their own. But those healthcare coalitions have emergency managers who are required to receive funding. In order for them to get funding, they're required to do a community-based exercise every year. They have local public health departments who are required to do a community-based exercise every year for funding. The coalition themselves now, in order to get funding, are required to do a community-based exercise every year. So the sort of the secret sauce for you guys is, don't try to come up with a community-based full-scale exercise on your own. Just go hop on with your healthcare coalition that already has 3 entities that have to do them already and participate. So the Gillette, great example. Gillette is doing a plane crash scenario coming up in that healthcare coalition. So Gillette, Buffalo, sort of that northeast side of the state. I know that they're doing because we're coming up to it, they're doing a plane crash scenario. If I was one of you guys on the phone and I was in the Gillette area, I would go get a hold of Campbell County Public Health or your local Office of Emergency Management and say, hey, I really want to be a part of the coalition. It's free. There's no cost. They will ultimately help you write a lot of the plans we're talking about already. And then say, you know what, can I participate in that plane crash scenario you're doing, that exercise, because that meets my community-based full-scale exercise requirement. And really, all you have to do to be compliant is, when they do the simulated plane crash, they'll call your organization, your practice, and say, hey, we've had this plane crash. We need you to activate your emergency response plan, yada, yada, yada. And you guys say, okay, great. We have activated our emergency response plan. Ideally, in your plan, when you finish the tools that we provide for you, one of the first things will be, how will we activate and how will we get this information? So we're going to activate. We're going to tell all the providers, hey, we've activated. You're not stopping providing care. You're not shutting down the business. You're still seeing patients, everything else. It's just information gathering. We have 1 MD, 1 NP, and 1 PA here now. We've got 5 MAs. We've got these many patients for the rest of the day. And based upon this event, we don't think it's going to impact us. You've gathered that information. You push it back up to your local county public health department. Your local public health department says, great, thanks. We've got that information. They're doing all the plane crash and industrial accident response kind of stuff. They may tell you, okay, we're going to have you on call. It's all just pretend. We may send pretend patients to you. They're not actually going to send anybody to you. They're just going to, yeah, we're sending you 3 patients. Okay, great, we got 3 patients. You have just participated in a community-based full-scale exercise. It's really as simple as that. Get on with the coalitions, as the coalitions do exercises, they will more than likely, the extent of play for most of you, if you want to do more, you certainly can. The extent of play will be ring, ring, hey, we've had a plane crash, activate your plan. You guys then go and get, what providers, what resources, what staff do you have, report that back up to the coalition. The coalition says, great, thank you. They may call you and say, well, can we send 2 low acuity ambulatory patients to your practice? Sure. They're not actually going to send anybody. It's just that the communication, the command and control piece, and then you've met this requirement. Without being a part of the coalition, meeting this requirement is almost impossible for a physician's practice, because you would have to go out and get everybody else to play. Fire, law enforcement, EMS, public health, other physicians' practices, long-term care facilities, hospitals. It's overwhelming. So just have the coalition do it. So I think I've beat that one to death. We've certainly got time, questions and answers at the end if you guys want to talk more about it. After you've done those exercises, evaluate it. We've already sort of talked about it. So there's something called an AAR, an after action review, that CMS is supposed to provide a template for. If they do not provide a template, it's really just as simple as coming up with a bullet pointed list that says, what did we do well in that plane crash accident or in the EHR downtime exercise, and what did we not do well? It's just listing it. It's sort of like a report card for yourself. So if CMS, and they have not yet, if they don't provide a report card template, which I don't expect they're going to do before November, just make a blank Word document that says, on this date, we did this exercise. This is what we did well. This is what we did not so well. And this is, sort of our findings. And then from that, you improve and you say, okay, we realize we do these 3 things well. We want to continue to do those things. We realize that we didn't do too well on these 3 things. So here's our plan on how we're going to improve on communicating with the physicians, notifying families, and we ran out of addressing. Here's how we're going to sort of address those issues, and it's really an improvement plan. So with that, I think the PowerPoint's done. This is certainly a time, Kathy, if we all want to go grab some donuts and take a little 15-minute break, we can, or we can, I think the tools should take us about 30 minutes, maybe 45 at the most, and we'll be done. It's up to you guys.
Okay. Let's go ahead. Maybe let's just do about 10 minutes.
Okay.
And then, so let's all come back about 12:15, and everybody can
Perfect.
grab some lunch and whatever you need to do, and then we'll go for about another 45 minutes to an hour, and we'll have time for questions.
All righty. Talk to you guys in 10 minutes.
Great. Thank you.
Mm-hmm. Let me say this best. Larger parent organizations, there's really a couple different ways that CMS is looking at this rule in terms of multi-site practices or practices that are part of larger entities. And I'll start by sort of summarizing my answer on all of them to say that they are specifically looking for across the board, whether you're part of a larger entity or you have multiple sites or whatever, they just want to see that the plans encompass every single subservice and functionality. So, in direct sort of answer to Melissa there or anybody else that's in that situation, it's sort of a matter of the larger entity that you are a part of has to have these plans, and those plans have to specifically address your practice. So there needs to be an HVA that's sort of unique to your practice. Their plans need to address how they will continue to provide care and how you will continue to operate in that practice, sort of as a satellite of their larger facility. The training needs to involve your guys' practice. The exercises need to involve your guys' practice in some way, not as significant probably, it could be a little bit less. But so if you're part of a larger corporate entity, it's a matter of their role is that their plans have to address you. You have to be, the HVA has to address you, the plan has to address you, the training has to be specific to your staff, or your staff have to be included in it. You have to, in some way, shape, or form, be involved in exercise and improvement plans. How you handle that with the larger group, and it does get somewhat interesting when, like maybe in Melissa's case with the Community Action Agency, maybe that larger group has nothing to do with healthcare at all. If they have nothing to do with healthcare at all, they will probably tell you, well, we're not making any of those plans because we don't have to. So then it's sort of incumbent on Melissa to do it all on her own, and that physician's practice or that primary care practice does all that work on their own. Or if the group above Melissa or anybody else on the phone is a healthcare provider, then you can sort of do that one big corporate umbrella plan. But in that umbrella, it needs to specifically address an HVA for each site. The plan needs to address how each site will operate. Staff at each site need to be trained. Each site needs to participate in exercises. Each site needs to do the evaluation and improvement process. That can all be done by a corporate, sort of like a corporate emergency preparedness person or plan, but each site has to be specifically addressed. So I guess the easiest way to sort of summarize the whole rambling thing I just said, because it's very hard to describe because there's so many unique complexities that people have in terms of corporate structure these days in healthcare. The easiest sort of way to summarize it all is to say you can absolutely have a corporate umbrella that does all of this work, as long as that corporate umbrella specific in their HVAs, in their plans, and their training and in their exercises, as long as that corporate umbrella specifically addresses your practice, your specific location, your risks, your staff, and all that good stuff, and your staff are involved, corporate umbrella can cover it. That's perfectly okay. If that corporate umbrella is healthcare, they probably are already doing it anyway. If that corporate umbrella is not healthcare, they are probably not going to do it, and it's going to be just on you to do it. But one way or the other, CMS is not going to accept the corporate umbrella, whoever does it, unless it addresses every individual practice and how that practice will respond, and staff are involved in the training and exercising and all that. So before we move in, I want to make sure that sort of answers Melissa's question and anybody else's. So I'll give it like 10 seconds if somebody wants to chat back and say yes, no, or otherwise. Perfect. Good. I'm glad that answered your question, Melissa. So if there's any other questions, we'll go ahead and dive right into these tools. These are the tools you're getting. Cassie and the Wyoming Primary Care Association didn't ask me to make this plug. I'm just making this plug on their behalf. This is why it's good to be a member of associations like the Wyoming Primary Care Association and your Healthcare Coalition. What we're about to go over is about $50,000 worth of templates, and you're going to get them for free just because you're a member of, just because the Wyoming Primary Care Association is having me talk to you today. So today your membership certainly paid off. So these are all the tools that you're going to use to be successful in complying with these tools. And I'll leave it up to Kathy on how this is going to get out to you guys. I don't have your emails. We don't do marketing email anyway. So that's going to be, Kathy, I'm sure, will get you guys these tools. Remember the first thing that we talked about that you had to do, that step one, is conduct that HVA, that hazard vulnerability assessment. That's the first sort of requirement that they're looking for. The first page of this tool is all instructions. It's written in my third grade reading level because I don't talk good and I write worse. So it really outlines every single thing that you need to do in very clear and very simple language to complete an HVA. Again, to sort of tag on to Melissa's question, if you have multiple facilities, either because you're part of a big corporate structure or maybe you're a primary care practice that has, locations in Lander and Riverton and somewhere else, I personally would encourage you to do an HVA for each site. They're quick, they're easy to do, and it's a lot simpler to just make an HVA for each site than it is to try to come up with, well, in Thermop this isn't a risk, but in Lander it's not, but in Riverton it is. That it's almost easier to just do them separate than to try to figure out how to make all the dotted lines and dashed lines coalesce. Remember that step we talked about on the PowerPoint? First thing is you're going to identify, and this is all in the tool. This is a Word document that you guys will receive. Then you'll assess, then you'll make a list, then you'll assess impact and probability. The scaling is right here. It's all described for you guys in the tool. You can give yourself some credit down here in mitigation and preparation. I do highlight in here, one of the things we say is don't overestimate the value of your preparedness activities. You can't go from a 5 impact to a 0 impact. That might be slightly overconfident on your part. And then you'll rank them. So here's how we would do that in a tool. This instruction sheet tells you what to do, but I'll walk you guys through it super fast. Remember, the first thing we'll do is you're just going to list all of the events. There's my alien invasion example again. We have provided a lot of different sort of examples for you guys here. You certainly do not have to use these. A great one for Wyoming is hurricane. You are not, if you guys are getting a hurricane, something has definitively gone wrong in the world, you don't need to address this one. You can delete it and you don't have to talk about it. We just sort of put all these in here as some examples for you guys to sort of jog your memory. But what we sort of suggest is, first thing, list everything that could go wrong, then do your probability. So basically just work right across the top, do your probability and say, all right, well, this is a 2, a 5, a 3, a 1, a whatever. Give yourself some credit for mitigation. And I'm going to take a quick segue here to talk about mitigation because sometimes mitigation is sort of hard to understand. And I'm going to use wildfire as an example because it's the best one to sort of illustrate how mitigation works. If your practice or one of your facilities is located on the side of a beautiful picturesque mountain surrounded by trees, your wildfire risk is obviously pretty high. But you have gone out, and because of that risk, you have gone out and said, we're gonna work, since we own the property, we're gonna work with the building owner to clear all vegetation 200 feet around the facility. Well, that's a mitigation step. So you can give yourself some credit for that. So we had pine trees right up next to the building. Our risk of a wildfire was a 4 or 5. We've cleared 200 feet of defensible space. We've talked to the fire department. They say, yeah, that's some pretty solid mitigation there. We may subtract 2. So you can see how you're making the event less likely to occur by giving yourself more defensible space. So wildfire is a great example of how you can mitigate. Other things, can you really do anything? Can any of you guys do anything about a dam failure? Not necessarily, unless you're going to go out and build all your practices on 20 high-foot stilts, which you're not going to do. So mitigation and preparedness are both sort of event-specific in terms of can you mitigate and how powerful is it. It's really easy to do solid, powerful wildfire mitigation or fire mitigation by sprinklers and all this other good stuff. It's really hard to do mitigation on a communicable disease outbreak. So you guys can't control that, if it makes sense. Once you go, you do this, the first column first, then you say, all right, what's our probability? What's our mitigation? You come up with your impact score here. This is really your goal, I'm sorry, your probability score. You do the same thing for impact with preparedness. Preparedness isn't necessarily things you're doing to reduce the likelihood of it. Remember, you're doing it to reduce the significance of it. So we do a ton of drills. We are constantly working with our staff. We have put a generator in, and we do generator tests where we switch all over to power. In a hospital we call it red plug power. We switch over to emergency preparedness power or emergency power, and we do that once a month. Well, those are all preparedness activities that you're doing that you can give yourself a little credit for. And then you'll finally end up with that impact score. The big thing I want to stress is if you have something like 3 here, you should really not have a 3 over here. You may be slightly overconfident if you're doing that. And I have actually seen this where I've seen like a 2 here and a 4, and they end up with a -2. That's impossible. So don't be overly confident in either the mitigation or the preparedness columns. Once you do, you get this gray, all you're going to do is come in here. It's a Word document. It's all there, and you just sort of going to chart out each little thing. And in the end, your focus is sort of this little triangle of doom right here. If you focus on that, you're going to be very happy, and that's what your plan should be on, because these are the events that are either extremely likely and extremely catastrophic, or some acceptable deviation from that range. This isn't the stuff that is never going to happen and won't hurt us at all, or it will never happen but it's catastrophic, like my alien invasion example. This is the sort of area that you guys really want to focus on for your plans. So that's the HVA. That's the first tool you'll get. It's very simple. All I would do if I was in your guys' shoes when I get this Word document is I would print it out. I would keep a copy of this first page for yourselves and then delete it electronically. Do this page and then that page. Save it under the file name of Mitchell's Primary Care Practice PC HVA, and then we're done. You have now completed the first part of that CMS preparedness rule. Any questions on the HVA? I'll give us a few seconds, so I got to pull up the next document, but that's essentially it. It's very easy to do. Perfect. So the next thing, I'm uploading it now. It's converting real quickly, is you have to create an emergency preparedness plan. And that plan, what we've done is we've sort of given you an outline in this toolkit. It's sort of the Cliff Notes version of what you have to do. It's a single-page document, and what that single-page document does for you is it's giving you each section of the plan that you need to fill out. And it sort of describes, here's your different sections, and it describes what you're going to sort of discuss or do in those sections. So it's all there. I'm not going to go through this specific document because we'll go through it on the plan itself. But this is really there to sort of say, it's sort of like an outline to help you keep track of where you're at and what you're doing in all the different sections of writing the plan. You would never give this to an instructor. Anything that has our logo on it, you would never, or an instructor, an evaluator, you'd never give that to anybody. It's really just there to help you. So that's that one, and now we're going to get into the big beefy one, which is the plan development tool itself. It's big. It's 25 pages. We're not going to go through all of it in painful detail because it is really self-explanatory. And in the end, you can, again, just take this electronic document when you get it and turn it into your plan. If you fill out this tool and the HVA and the other tools that we've given you, you are compliant. So why not leverage that? The first page in it is, again, remember, our logo. If it's our logo, you wouldn't print it out. It's not part of your plan. It's there to help you. The first page really goes over everything that I just went over on this PowerPoint. So it's all there for you during this webinar. We do have the little caveat in here that the tool is made to, it's a universal tool, so you got to sort of make sure it makes sense to you and do some work in that regard. We don't know your organization, so we're sort of, it's generic. I know we are a consulting company, but that is not what we're in the business of doing. We're actually really in the business of trying to make you guys compliant and helpful. So hit us up with questions. We don't charge for that kind of stuff. We write plans for people, and that's obviously something we bill for. But hey, I sat on that webinar that we did. Quick question for you, what it is. That's always free. We don't bill. I want you guys to be successful. You are in the business of helping people. We're in the business of helping you do that. And I'm more than happy to help you guys out with that, with questions and stuff like that. So there's ways to get a hold of the team. The next page, page 2, is instructions. It really truly is written, and I've got it zoomed in a little bit. Here we go. It really is truly written to make you guys successful. It goes over the entire process. It even reminds you to save a blank copy of the tool because you don't want to corrupt your only copy. And then this is the big part I really want to cover on this plan, or this tool for right now, are these 3 things. In every single section on this tool, you will see these 3 sort of components. The big blue box, as we call it, it's not Walmart, it's the section explanations. It's very simple, very intuitive, sort of an intro to say, this is what this section is all about. It sort of helps put you in the right mindset to write that section. After you get into that, as you start working through stuff, you'll see red italicized text. That is truly, we've put that in there so you can delete it and replace it with your text for your plan. And then finally, at the end of every section is a checklist. So if you think about it, it's sort of a feedback loop. You say, what do I need to do? I'm going to do it. Did I do it right? And you are set up for success. I will always tell you to save the file often. There's nothing worse than getting to page 30 and realizing you never clicked save. And then down here in the last piece is some formatting notes. On these formatting notes, we have built the entire thing, so it's formatted, it's got the page breaks, it's got everything you need to make a pretty looking plan that's very compliant. If you go and select all and click delete, that all goes away, and then hopefully you did that blank copy that we talked about. But right now it's all set up for you to make it to where you literally are filling in the blocks, the blanks on a Word document. And then I'll put in there as well, delete these first 2 pages with our logos on it, because you don't want to give that to the instructor or the evaluator. So here's your plan. Here's your header page for it. Feel free to put your organization name. The plan has to be reviewed every year. They will check that. If you have a logo, you can put it there, replace your facility name. You're done with that first page. Signatures, oh, you can delete this information. Here's the only thing that we sort of request. As I mentioned, we're giving you about $50,000 worth of stuff for free. I don't mind doing that. I'm the owner of the company. The only thing we ask is that you don't go give it to somebody else that's going to charge a bunch of other physicians' practices and healthcare providers a ton of money to do this. More than happy to do a good deed and help you all out. Just please don't give our good deed to somebody else that's not going to follow the same spirit. So it's all copyrighted. You're more than welcome to use it to write your plans. You can't use it and you can't give it to anybody else to make money off of it, is sort of where we're driving at with that one. Signature page in here for you guys, date last reviewed, needs to be reviewed annually. And then in here, just whoever you deem is appropriate. If it's a single provider practice, maybe it's I don't know you guys' specific requirements up there. I know down here in Colorado, for instance, my wife's an NP. She can own her own practice. So in that case, it could just be my wife's signature right here, and that's it. That's the only person who needs to sign it. If it's a multi-provider practice, maybe you want to have the multiple providers. Maybe you want to have the practice manager. These are just the decision makers in the organization who are basically saying, we've reviewed this plan. We are attesting that this is our plan. Not necessarily something that's going to come back and get you legally, but I will definitively tell you on an inspection, they will 100% want to see that this is signed by the decision makers in the organization. Again, you can just replace your facility name and you're done. Table of contents is already built for you. It's already there. All you need to do is update page numbers. That's explained on page 2. And you don't even have to do that. All you do is you click in the Word document and say update page numbers only. It's all formatted. It's all linked. If you're showing it in an actual PDF, you could come down here and click technology, and it would take you directly to that page on the PDF. I mean, so it really is truly set up. All you need to do is click update page numbers. So now we'll get into the sort of sections of it, and you can see how this plays out. The blue box says basically the executive summary is the summary. We have already provided most of the sort of legalese information for you. If you choose to, all you have to do is come in and replace these 2 spots with your name, and you are done with your executive summary. And if you have anything else you feel worth mentioning. You come in here when you're done, you read the blue box, you replace the red text, you say, yep, I've done all these things. You are done with page 1, the executive summary. Purpose and scope, same thing. Sort of says what you need to do. We've already sort of provided you the canned verbiage if you want to keep it. And then you just do your check boxes when you're done, and you're done. Same thing with scope. It's done. As you can see, we're starting to get into more of the stuff that's somewhat more specific. It's sort of hard for us to come up with too much canned verbiage on some of this stuff. If you have multiple facilities, what are the facilities that are covered? Our Lander Clinic, our Riverton Clinic, our Casper Clinic. Clinical services, we are only primary care. We only do primary care. We're primary care, but we also do testosterone and allergy and asthma, whatever else. It's really truly what you guys do. I realize some of that's a little gray, and we're moving out of family practice world, but whatever you guys want there. Clinical admin staff and other unique considerations, not overly detailed, excuse me, just informative enough to sort of say this is what our plan, this is the scope that our plan covers. Do that, do your check boxes, you're done with you now done the first 4 components of your plan. Assumptions are a little bit goofy, and I'm going to sort of summarize what this blue box says. Assumptions are things that you take for granted. They're things you are assuming to be true. In the event of a major disaster, the Office of Emergency Management will be activated. Hospitals will be overwhelmed. And if I call 911, somebody's going to answer. That's an assumption. Assumptions are almost like your get-out-of-jail-free card. You are saying in this assumption section, I assume that when I call 911, people will come. I assume that patients will come to my facility. I assume that I will have less resources. I will assume that I will not get supplies. It sounds like, well, why would we put that up there? That's sort of the duh moment information. But it's always helpful to put it there because you're sort of providing yourself a little clemency in the event that it doesn't happen. I called 911, no one answered. You guys know that we are in one of the most litigious societies on the face of the earth. It certainly can't be bad to have in your emergency preparedness plan, well, we assumed that if we called 911, somebody would answer, and somebody didn't. And that's why we had this outcome personal injury attorney. This is your attorney talking to their attorney, of course. So we assumed it. We sort of covered our bases. We weren't negligent in our thought process here. And we have seen that save people in situations before. So the hard part about doing assumptions is if you sit down and you go through from page 1 to page 30 on this thing and you say, well, I can't go to the next page until I do all my assumptions, you're going to spend 4 weeks coming up with every assumption you could possibly come up with, and it's going to be a waste of time. So what this blue box tells you is just get a scratch piece of paper on the side. And as you're writing your plan, or you can put it in this if you're savvy enough to scroll up and down the document, the Word file. As you're writing your plan, say, we're going to da-da-da-da. Oh, I'm assuming that the phones will work. Just jot that down on the end, and later on go put it in your assumptions area. Don't try to come up with all your assumptions ahead of time. As you write your plan, the assumptions will come up sort of naturally. Then just jot them down and then fill out this section. So this is more of a living kind of section of the plan. Organizational summary. Blue box basically says this is where you're going to outline your facility. This is not a CMS requirement, this specific section. But spending this 30 minutes outlining your organization and outlining the stuff we're about to go over will make your life significantly better when you're writing your plan. Just list, what kind of provider are you guys? For all of you guys on the phone, that's pretty simple. We're pretty much ubiquitous. What's your patient population? Is it predominantly elderly? Is it predominantly young? In Gillette, is it predominantly young guys in the oil fields or in the industry up there? What's your acuity? Make sure you're putting percentage. These are our at-risk folks. These are our COPD patients. These are our folks who are already immunocompromised and have significant comorbidities. That is the stuff that your health department's going to really, 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 really want to know. Because those are the people that are going to require the most care, and there is simply not enough ambulances and hospital beds for us to be reactive in how we treat them. So the more information we get up front, the more data we get up front equals better planning throughout the whole community. So these patients are not only going to be the most concerning for you, they're going to be the most concerning for everybody else in the healthcare network as well. Treatment provided, for those of us on the phone, it's pretty simple. It's all somewhat ubiquitous. Understand that this tool is designed for everybody under the sun. It's not made specifically for physician's practice or primary care. Staff duty, pretty simple. On this one, and I have seen this happen once before, please do not list patient names or any patient identifiers. It's very broad. 10% of our population or 200% of our patients, or 200 patients or 10% of our patients are COPD. Very broad. Now patient identifiers, you don't want to get a HIPAA complaint in your emergency preparedness plan. Facilities, equipment, resources, and tech. This is not how many stethoscopes and sphygmoid thermometers you have. This would be anything that's very, very, very unique. In a primary care setting, I can't think of an example that's really good, so I'm going to use dialysis as an example. In a lot of the areas in Wyoming that we've worked with, there's only one reverse osmosis machine in a 3-county area for renal dialysis. That is a critical piece of equipment that needs to be thought of and highlighted, not how many stethoscopes and everything else we have. Resources as well. Again, I'm going to continue to pick on dialysis and renal, the renal fluids, the Fresenius fluids. That's a critical resource. Tech. Well, we're the only provider in our entire county that has X-ray or you guys don't have CT or MR, but there's something that's very, very, very specific to your organization that's very important. That's a huge resource. Do your checkbox, and you're done. After that, really, here's what this blue box says. You can do one of two things. That table that we saw in the first Word document right after break, you can copy and paste it in here, and you're done. Don't want to take the easy route, and you want to delete this blue box and list it all out, that's the other option. So that's sort of your two choices. Copy and paste the table and put it in there, or rewrite everything. That's really all that blue box says. Then you're going to do an analysis of those hazards. This is very simple. It basically just says, of the 3 things that concern you the most, just tell me a little story about them. It doesn't have to be super big. We face the greatest risk from whatever. There's other considerations. It's not an example I'd put on your plan. Well, actually, you know what? If any of you guys are in Cody or Park County or Afton or Alpine, seasonal surges. Seasonal surges of non-English speaking patients is certainly something that maybe not impacting you because they're not establishing themselves as they're not established patients, but maybe you have, maybe Jackson has a lot of winter or summer only residents, and your patient volume doubles. That's something I would list. Do your checklist at the end, you're done. Critical services and functions, this is a required part. Basically, all this blue box says is we absolutely have to do these things. They are critical. You cannot operate without these things. Non-essential functions are the opposite. And I'll use an example outside of the primary care world. I'll use a hospital example, so I apologize for that. When I worked at a healthcare facility, major healthcare facility, we were doing this process and we were listing, ER, MR, CT, ICU. These are all critical services and functions that we have to maintain. And we got down to the gift shop, and the gift shop manager was absolutely adamant that she actually was a direct report of mine, and she was adamant that she was a critical service, which is essential. It was for the health and welfare and morale of the staff. But that's not a critical service. So you got to say, what's essential? What do I absolutely have to do? Is in that top part. What can I do without? Is in that second part. And you're really just listing, these are the ones that I'm going to stop doing. That's sort of, remember all that admin stuff from the PowerPoint? I said there's two parts of the plan. There's admin stuff, and then there's operational stuff. By consolidating those three plans into one document, we've made it to where you only have to write the admin stuff once. So we're saving you from writing that admin stuff 2 to 3 times by consolidating it all into that one piece. And we've just done all that admin stuff. The emergency plan is the next section. Again, you could just replace your facility name. You would delete this because you're all going to be super compliant with it, which I appreciate. You get right into your concept of operations. Essentially what the blue box says is everything I told you in the PowerPoint. What is the very high-level command and control and coordination stuff you're going to do? So here it is, and we've sort of put these things in here to sort of jog your memory. As soon as we find out the event will happen, staff are going to, we're going to notify all staff about the event, and staff are going to report, and we're going to get a head count of what physicians, what MAs, what clerical admin staff, what mid-levels, everybody else who's at work. We're going to get an idea of how many patients are still coming in. We're going to get a quick inventory of supplies. What are you going to do immediately upon the event? Then as the event occurs, and remember, we're all hazards now. So it's not specific event. It's in general, if we had an emergency, this first part is going to be pretty much the same across the board. How are we going to maintain continuity of operations and care is the second part. Not how will we treat respiratory patients in a novel influenza outbreak. No, that's not what we're talking about here. How are we going to continue to provide care regardless of the event? So we will make sure we rotate staff. We will do every 3 hours, we'll do a check on supplies. We will call all of our non-critical patients and say, please stop, don't come in for your routine physical today. We can't do physicals because we have a huge influx of patients from other events, those kind of things. Prolonged event, understand that, and we'll use H1N1 and Ebola as an example. And I say this very cautiously but comically. None of those events for us in the continent of the United States were pandemics. They were dang panics. So, but we can see the impact that they had on our healthcare network. So the event will probably go on for a prolonged period of time. How are we going to continue to operate in those prolonged periods of time? And then following event, what will we do to sort of return to normal? So all of those routine physicals that we rescheduled, how are we going to fit them back into the schedule 2 weeks from now? Again, another great reason to be part of your coalition. If you're in the coalition and you're helping respond to an event in these post-event activities, you could actually be reimbursed for a lot of expenses. It's not a fast process. It's not an easy process, but you can at least make some money back in the process. So, these are sort of the things that you want to consider. But really, you're just going over your concept of how you'll respond in an emergency. The checklist is very detailed. I'm not going to go into it too much because it's sort of self-explanatory. Your communications, that's it. You've written that first plan. Your communications plan, what this blue box says, is essentially what you need to do is you need to think about what you're going to communicate, how you're going to communicate it, when you're going to communicate it, and if it's patient data, how are you going to protect it? Because you are still going to have to make sure that you're protecting patient privacy, even in an emergency. How will you do that inside your organization? How will you do that with EMS, hospitals, other providers? How are you going to communicate with staff? Just tell staff where, what time to show up to work, modified schedules, modified hours. You can do that via voice, phone, whatever. How often are you going to do it? How are you going to tell the families and visitors? This is certainly less of a case for a primary care practice. This is more of a case for a long-term care facility or physician's practice. And how are you going to communicate outside the healthcare network? Again, I'll just say that the simple answer to this is be a part of your healthcare coalition. They'll take care of all of this for you. Vendors and suppliers, government and other response agencies. This one is absolutely 100% in the CMS requirements. So do not skip this section. And really the simple answer to this one is, I just keep harping on it, is that healthcare coalition. Let them do the work for you. Here's very simple what the blue box says. If you think about it, we just listed how we're going to communicate with who. This is just sort of like we're going to make some call rosters for those different things, for government response, suppliers, internal staff, all that good stuff. And then we get into annexes. And this is the third part that they're looking for. You have just written all those plans. We're good to go. Annexes are the very specific things. How will we specifically cancel all of our non-critical services? It's a very specific, detailed function. I'm trying to think of a good analogy. All of our staff will be BLS certified. Well, that's more of a concept of the operations big picture thing. The specifics of how we're going to do that is every year as part of the review, we're going to look at their CPR, BLS certifications, and they all have to be certified by AHA or whoever we're certifying with, and da-da-da-da-da-da-da-da-da-da-da. It's very detailed. They'll have to provide us a copy of it. We will put a copy of it in their file. It's very specific, detailed stuff on critical things that you need to do. That's what an annex is. The first annex will be those functional annexes, which is those very detailed things, those policies and procedures. We've given you a list of some of the things that they're really looking for. On some of them, they don't matter, and you can see that we put in here for you guys, inpatient and residential facilities only. You don't have to worry about evacuation. So don't do these as a physician's practice. It's not your concern. Engaging with these other guys, though, and transfer continuity of care, maybe it wouldn't hurt to have a policy for those. How we're going to shelter in place wouldn't hurt. We don't have to worry about providing sustenance as a primary care, so we're going to get those out. How are we going to maintain medical records? This is where, again, I'm not going to go into too much detail on providing care and emergencies and crisis standards of care because it's very unique to Wyoming. So, this is where, again, that healthcare coalition makes life wonderful for you. And we've given you a template to do that. So, hopefully I don't make this too bad, hopping all over the place. We're going to make a policy for tracking staff and patients. All we're going to do is come to this template and say policies and procedures for tracking staff and patients. The blue box basically says use this if you want, or if you want to have your own specific one that you guys already use to do policies in your organization, great, use that one. But in general, just make sure that you talk about a policy where we will do these things. These are the rules and the procedure, how we will do these things. How will we, our policy is that in an emergency, we're canceling all, in the event of a large-scale emergency, we're going to cancel all routine physicals. And again, it's just an example. I'm not saying that's what you got to do. So that's our policy. We will cancel all routine physicals. How we will cancel those routine physicals is we will look at the schedule for the day. Well, The providers will make a determination. Step 1, providers will make a determination that routine physicals need to be canceled. Step 2, we will look at the schedule and get a list of all patients who are scheduled for routine physicals today. Step 3, the front office will call all those patients and tell them to do the emergency, routine physicals are canceled. So that's sort of your policies and procedures template. All you do is you just copy and paste this page, make a new template, make a new template, or I'm sorry, make a new policy, make a new policy, make a new policy, and you're done. Hazard-specific annexes, I doubt any of you guys would have these, but this is, I am a primary care practice directly across from a nuclear power plant or oil refinery or the train yards. I'm a block away from the train yards in Cheyenne, and you probably need to have a specific annex for how you will respond to a train derailment, because it's going to be so far outside of an all hazards event. It's so specific and so unique that you need the specificity that you cannot do in the overall universal plan. And that's all explained here in the blue box and how to fill it out. And then finally, if you wanted any tools or notes or anything else under the sun, this is your last section to do that. And then really, guys, all you do is you fill this out, delete those first 2 pages, save it as your organization's, CMS emergency preparedness plan, and you are now compliant. And this is all they need to see. The only last tool, it's like 30 seconds max for me to go over. So while I load it, are there any questions on that? And then we'll go over the last tool when we're done. Okay. So it is uploading. Hopefully I haven't just bored you guys all on the phone. The last tool you're going to get from us, or I guess from Kathy and the Wyoming Primary Care Association, is this one. It's just some general tips, sort of already gone over everything for how to do the training that we've talked about, and then how to do the exercise. And then really this just sort of breaks down the language of what a exercise is and what they're looking for, and then the requirements for it. So with that, you guys are done hearing me blab, and Kathy, I'm done, so I'm more than happy to open up for any questions.
Wonderful. It does look like Tom is typing something, so there it is. We will send all of this to Kathy, and she will send it out. Yes, Tom, everybody that is on the call, I should have your email from your registration with Constant Contact. I will send this information out to everybody that's on the call. All right, any other questions? Welcome.
Oh, I think Dave's typing. Awesome. Thank you, Dave. And if you guys have any other questions, remember that information either through Kathy or on that first page of that plan template. We are here to help you. So that's what we got.
Great. Thanks so much, Chris. You did a great job. A lot of information. This webinar was recorded. We will have it as well on the WYPCA website, probably in about a week. So if you give us a little bit of time, we'll get that up there. Also, there's a survey on your screen. If you could just take a few minutes to fill that out, we would greatly appreciate it. Thanks again, Chris, and thank you, everybody, for attending.
All right. Have a good one, guys. Thank you.